and welcome to SCAI's Conversations in Interventional Cardiology. My name is Suzanne Baron. I'm the Director of Interventional Cardiology Research at Massachusetts General Hospital. I'm also the Deputy Editor for JSCAI, and I'm honored to be here representing SCAI and JSCAI. Today, we're here to discuss a really important document that was recently published in JSCAI titled Forward Flow in Patients with Heart Failure and Functional Mitral Regurgitation, Results from the COAPT Trial. I am lucky enough to be joined by an absolutely esteemed panel of leaders and experts. Dr. Gertz, who's an Associate Chair of Internal Medicine for Outpatient Operations, Director of Structural Heart Disease, and an Assistant Professor at VCU Medical Center in Richmond, Virginia. Dr. Gregg W is Director of Academic Affairs for the Mount Sinai Heart Health System, also Professor of Medicine, Professor of Population Health Sciences and Policy at the Icahn School of Medicine at Mount Sinai, New York. And Dr. Lissa Sugeng, who's Co-Director of the Yale Echo Core Lab and an Associate Professor at Yale University School of Medicine in New Haven, Connecticut. Thank you so much for joining, and I'm going to turn it over to Dr. Gertz to get us started with this conversation.
As suggested, we're going to talk about forward flow in patients with heart failure and functional mitral regurgitation from COAPT. So some quick background: heart failure with reduced LV ejection fraction results in reduced forward flow. Whether forward flow is further reduced in the setting of heart failure with functional mitral regurgitation is not well known. Forward flow is a strong predictor of outcomes in patients with aortic stenosis and degenerative mitral regurgitation, but its utility in prognosis in patients with functional mitral regurgitation, again, not well known. And in both of those valvular diseases, changes in forward flow after intervention are associated with outcomes. But again, whether that is true in patients with functional mitral regurgitation is not well known. Because of all those not well-knowns, we conducted this sub-analysis from the COAPT trial. I suspect we're all pretty well familiar with COAPT, but some quick review. Patients with reduced ejection fractions, EFs of 20 to 50%, functional mitral regurgitation of at least 3+, and symptomatic despite optimal medical therapy. Patients could not have severe pulmonary hypertension or moderate or severe right ventricular dysfunction. Patients were randomized 1-to-1 to guideline-directed medical therapy or guideline-directed medical therapy with transcatheter edge-to-edge repair of the mitral valve with a MitraClip. Patients had echocardiography throughout the study, analyzed by a core lab, and we measured forward flow as stroke volume in the left ventricular outflow tract indexed to body surface area. The primary analysis was the baseline stroke volume index and either death or heart failure during 24 months of follow-up. And we did sub-analyses, including changes in stroke volume index at 1 month and the association of that change in stroke volume index at 1 month with outcomes through 2 years. Getting to the results, this is our primary outcome. First, we divided the patients into tertiles of forward stroke volume index. Lower stroke volume index, lower forward flow, was associated with patients being younger, non-white race, non-ischemic etiology of their heart failure, larger left ventricles and left atrium, lower left ventricular ejection fractions, and more often severe mitral regurgitation as opposed to 3+ mitral regurgitation. And here we can see the outcomes between stroke volume index tertiles and treatment, so 6 groups. So intervention with TEER or not, and then stroke volume index tertile. And we can see in these top 3, these are the medically managed patients, and there's a pretty good spread between the outcomes based on tertile of stroke volume index. So worse outcomes were associated with lower forward flow. Interestingly, these 3 groups are the patients who were treated with TEER, MitraClip, and you can see there really is no significant difference regardless of baseline forward flow if the patients were treated with MitraClip. So again, as mentioned, this is a significant interaction for a significant association in this group and a non-significant differences in the group that was treated. And the other major outcome we were looking for, which is stroke volume index over time. And here it is over 2 years. And you can see compared to baseline, no significant change. And between the 2 groups, patients who were medically managed only in red, and patients who received transcatheter edge-to-edge repair in blue. You can see here, even especially at 1 year, absolutely no difference in forward flow in either group. Interestingly, there was just almost exactly 50% of patients who did experience an increase in stroke volume index. So didn't vary by group, but there were just about half of patients with an increase. And if a patient had an increase in stroke volume index at 1 month, it was a strong correlation with mortality. And if not TEER, what was associated with improved stroke volume index? Male, having lower forward flow at baseline, and having severe mitral regurgitation as opposed to 3+. Again, there was no interaction based on treatment group. So our conclusions from the study: lower baseline forward flow correlates with outcomes in medically managed patients with functional mitral regurgitation, not in patients treated with transcatheter edge-to-edge repair. TEER benefits patients regardless of stroke volume index, but the patients with the lowest stroke volume index appear to derive the greatest benefit. And TEER does not lead to improvement in forward flow, but patients in whom forward flow improve appear to have lower mortality. With that, I'll stop my share and turn it back over to you.
That was a great presentation and certainly brings up some really interesting questions. So I'm gonna throw one right at you, Zach, and then I'll open up to the panel. I was a little surprised when I read this to see that TEER didn't, improve your forward flow. Why do you think that might have been?
It's a great question. Obviously, when we set out to do this, we thought we would get the opposite result, but that's why we do the study. I think there is a big difference between forward flow and backward flow. I think that MitraClip pretty much stops the backwards flow, right? We've all seen the mitral regurgitation go down to 1+ or 1 to 2+, but it does not translate into a 1-to-1 pushing forward. I think it's easy for the blood to go backwards. There's no resistance back there, and a dilated mitral annulus might just let it happen, but that doesn't mean that the heart is strong enough to push forward against the heavier resistance of the body. But I would love to hear what your panelists think.
Lisa?
Yeah, I was very surprised as well with the no change of stroke volume over all the groups and the outcomes. What brings to mind for me is this concept of disproportionate and proportionate mitral regurgitation. And maybe there is another echo parameter that we just haven't accounted for, which is the underlying myocardial dysfunction. If we measure that by strain imaging, could that have uncovered some of the differences in those who improved?
Gregg, I'll ask you. You obviously know COAPT so well, and as you take this data in conjunction with MITRA-FR, what are your thoughts about these findings?
Well, I guess I wasn't that surprised, actually, that there was no increase because we've previously seen no increase in left ventricular ejection fraction, okay, which of course is difference between end diastolic and end systolic volume divided by end diastolic volume. And that's because, with mitral regurgitation, you obviously have a situation of decreased afterload, right? When you're regurgitating back into the left atrium, it makes it very easy for the ventricle to contract. And when you relieve the mitral regurgitation, you actually increase the afterload to left ventricular ejection. And these are not healthy ventricles. And so it's very different than in primary mitral regurgitation, where the ventricle is healthy unless you wait too long and then relieve the mitral regurgitation. But here, these are sick ventricles. And actually, when you've got to remember, when you see a left ventricular ejection fraction of 60% in a patient with severe MR, that's probably more like 40% or 35% because of that reduced afterload. So it's not that uncommon that when you really have a bad ventricle and you relieve MR, that the ejection fraction actually goes down. So we actually saw overall that there was no change in ejection fraction from prior studies from COAPT and no major differences in long-term left ventricular remodeling. And I think this is also a reflection of that. So what we're mainly doing with the MitraClip is actually reducing left atrial pressure. That's very clear. So decreasing pulmonary vascular congestion, decreasing preload. And ultimately, that's got some favorable responses as we saw mortality decrease over time, especially beyond 1 year with longer term follow-up. But it's not really because of, as far as we can tell, increased forward cardiac output.
Interesting. When I look at this, I start to think also about how can I use this, for those who are listening, how can we take this data and apply it to, the next patient who shows up in any of our offices, with, severe functional mitral regurgitation who are being considered for MTEER. So I might throw that to you. Zach, how are you kind of incorporating these findings, or are you incorporating these findings, and how so, into your clinical practice?
Yeah, exactly. I think the most important thing we learned here is that low flow is bad. Those patients with the lowest forward flow clearly have the worst outcomes, and those are the patients I think we need to be treating quickly. But everyone still benefits. So I don't think I would use this data to exclude anyone from MitraClip, but I think I would use it to identify patients who maybe need to get a faster workup and get to the lab more quickly.
And Lissa, you had brought up, looking at other parameters that we may be able to, from echo parameters that we may be able to incorporate in. You had brought up proportionate, disproportionate flow. If you could pick the next one that we should be studying or we should be looking at or incorporating into our patient care, what would you suggest?
Yeah, I think one of the things that an echocardiographer could probably do better is reporting some of the volumes and stroke volume index. And I think that's one of the major data points that we don't always highlight. We're always stuck in LV dimensions. Even though the chamber quantification guidelines by the ASC have emphasized volumes, but it's very difficult to propagate that guideline to day-to-day routine cardiology practice. Secondly, I think strain imaging might play a big role in the future. There are very limited data in patients with FMR stating a particular cutoff for strain. The issue with strain is that not every cardiologist has an echo machine that can do strain reliably, and it takes time to get good quality data. So,
and Gregg, I'd love to throw to you at this on this question is obviously there are many new mitral devices that are being evaluated and studied. In this patient population, should we be considering forward flow and stroke volume index as inclusion-exclusion criteria for trials, or patients that we should be looking at to target to study further?
Yeah, no, it's a great question, and the devices that seem to have most attraction for more study in this space is, of course, transcatheter mitral valve replacement. And that will do even a better job of eliminating mitral regurgitation, but also further increasing afterload on the left ventricle. So I don't know if there's going to be a major difference there. It's really interesting. I mean, we've got all these different ways of looking and measuring things with echocardiography or cardiac MRI, et cetera. And we all want to get away from left ventricular ejection fraction, right? Because we think it's too simplistic, it's a derived measure, it's afterload, particularly afterload, but also preload dependent, et cetera. There's variability for measurement from one person to another. But really nothing seems to do that much of a better job in terms of a prognostic parameter. I haven't seen strain, which is also afterload dependent, separate itself out from LVEF in many studies. Here we see forward flow is not separating itself out particularly. It's a useful parameter. We probably need a better non-invasive way to assess left atrial pressure. I think that would be useful, but we just don't have that yet beyond maybe the E to E prime ratio. So I don't have any brilliant words except that that it just does not seem to be that easy to discard the utility from looking at left ventricular ejection fraction across a whole range of cardiac structural syndromes.
Well, Zach, I'd like to give you the last word as the primary author of the paper, as well as the presenter today. Next steps, where do we go from here?
Wow, thank you for the chance to answer that one. I think where I would look now, because I want to understand what is the mechanism of the benefit from TEER. And I think it is decongesting. And I think what happens with long-term congestion is it propagates to the pulmonary vasculature, to the right heart, to the tricuspid valve. And I think that's where I would want to go next. But of course, I want to hear what Gregg and Lissa think.
Gregg, Lissa, any thoughts on that?
I think as physicians, we just wait too long, right? So we tell our patients that there's severe mitral regurgitation, but the LV hasn't dilated yet, so we're waiting and waiting. And so I think what would be wonderful to think about is choosing the right time, but not waiting too long for the LV to suffer, right? So finding that sweet spot of significant mitral regurgitation, but not significant myocardial dysfunction so that the patient doesn't improve.
Right, and I think that was one of the big differences between COAPT and MITRA-FR, that there's a lot of excitement about treating even earlier, right? Mm-hmm. Even treating, moderate MR in patients with non-dilated left ventricles, and hopefully there'll be an announcement about a trial looking at that pretty soon. But, I just wanted to get back quickly to Zach's comment, because I think it's really insightful. The more and more I think about it, in COAPT, you saw this huge difference in mortality, okay, which started to emerge after about 9 months and persisted for 5 years. And we didn't see much going on the ejection side of the heart. We don't see an improvement in ejection fraction. We didn't see major LV remodeling, but we saw this marked reduction in mortality. And I think Zach is right. It may be due to long-term effects from the right heart, which we all are appreciating more and more is a very important, prognostic correlate. With every millimeter of mercury increase in mean pulmonary pressure, translating to lower mortality and higher heart failure hospitalization rates. So it may actually be more chronic effects on the right heart as opposed to the left heart that causes a lot of the morbidity and mortality and heart failure syndromes. So that we should look at in the future.
I think it's a wonderful way to wrap things up. I think it's important to think about the fact that with all these new percutaneous devices, we're able to evaluate patients earlier and earlier in their disease process. We're seeing this for the aortic valve. You're starting to think about it for the mitral valve and tricuspid, the often forgotten valve that we weren't doing anything about until, patients needed something done to the left side of the heart. We're now being able to treat that too. So it's a really exciting time, I think, to be in this space. I want to thank my panel and our presenters for being here today and having this interesting conversation. And thank you to SCAI and for JSCAI for sponsoring this.